So as I understand, the father is healthy, but there was one child with hydrocephalus and meningocele. Okay. When he had another child with hydrocephalus and meningocele, what is the recurrence risk they are asking? So here, the incidence of meningomyelocele varies widely by the ethnic population and geographical location, but ranges between 0.2 to 4% per life. Girls are more frequently affected than boys. Recurrence risk is 5% increasing to 15% if two siblings are affected. So the recurrence risk is 5%, but if two siblings are affected, it will increase to 15%. So we will go to our question and check back the answer. Okay, suppose if if the father is affected, then the recurrence risk in the child will be 5%. But if two siblings get affected, then the recurrence risk will become 15%. The same thing is given here once again. Here you see spina bifida, isolated neural tube defects, a multifactorial disorder, carry a recurrence risk of about 2 to 4% after one affected pregnancy. If one child, then there is a recurrence risk of 2 to 4% for another child. But if there are two children, then it will become 10 to 15%. This is what we have to remember. Okay. So baby 3 months old, feverish with increasing irritability for the last 3 days. Today developed rash on his face and hands and all over the body. GCS is 10, normal blood picture and ABG conscious. So there is fever, age. We have to now make a list of what we got. 3 months old, fever, irritability. Okay, 3 days for 3 days. Now today develop rash on face, hands, and all over body. GCS is also dropping. It is 10. But normal blood picture and ABG. The baby is conscious. So you will consider lumbar puncture for diagnosis. Okay, I hope it's clear. Okay, suppose you don't have EEG and EEG is not available. The question is, which is better, MRI or CT in diagnosis of cause of convulsion if EEG is not available? If EEG is not available, what is the best thing you will choose for the cause of convulsion? So MRI. They have written MRI. Anyone has idea about these things? Okay. Baby convulsion at night, drooling, plus normal EEG. What do you suspect? Usually there is convulsion at night and also there is drooling at night. But when you do the EEG, it is normal. So the The options here is idiopathic frontal epilepsy, idiopathic occipital, myoclonic infantile epilepsy. So we have to check in myoclonic infantile epilepsy, EEG will be normal and they present usually at night and they will be drooling.
I
Okay?
think this is the benign myoclonus of infancy.
Yeah.
In this condition, EEG is normal.
Yes. Normal EEG is in benign uh, infantile epilepsy, right? Benign myoclonic infantile epilepsy.
And
Yeah, tell me.
in the previous question, I was thinking that we do MRI and CT scan depending on the site of the lesion. Na? Is it bony lesion? Is it soft tissue lesion? I think that is the reason behind that
Yeah. Usually, I think in a case of
MRI and CT
convulsion,
scan.
yeah, usually in a case of convulsion, I think it will be a lesion in the brain, not in the bones. So MRI will be more preferred than the CT, right? To see the brain tissue, MRI is more better than the CT. CT is good for both,
Yes.
but for the brain, MRI. And convulsion, usually it will be an injury to the brain more than the bones. So if EEG is not present, MRI will be the next best option. And normal EEG means, as you said, benign infantile epilepsy, this one. Benign infantile myoclonus. So you think that it has epilepsy, but it is normal. Full term, cesarean section due to fetal bradycardia. There is fetal bradycardia and hypoxic ischemic parasagittal. So if there is parasagittal injury, what they develop usually? For the parasagittal injury, they develop quadriplegic CP. Okay. But when they develop diplegic, when they develop diplegic CP, we should know which part of the brain is injured, they develop
That
diplegic.
is periventricular area
Periventricular
in
leukomalacia.
neuromalacia
If
in
there is
diplegic CP.
Yeah, if the periventricular leukomalacia will have diplegic CP. If parasagittal area in the brain is affected, we get quadriplegic CP. Similarly, hemiplegic. So I think better we will check the picture for this. Okay. So for this cerebral palsy, they had given three options. One is diplegic. One is diplegic, quadriplegic, and hemiplegic. So depending upon the area of brain damaged, it will be. So here you see the pink color, what they have illustrated is the area of brain damage, and green is the normal area, and this brown is the affected area. So you see the quadriplegic CP, there will be extensive damage. But in the diplegic, there is less. This is limited to here. But in the hemiplegia, as we know that if right side of the brain is affected, the left side will be affected on the body. So here he is showing the right side brain is affected and there is affection on the, sorry, left side brain is affected and there is affection on the right side of the body. But what I read there is Usually they are telling that affection in the parasagittal area will cause the quadriplegic CP, and periventricular leukomalacia will cause diplegic CP. Okay. So the next question, child 10 months. So child 10 months old, there is squint. The answer will be referred to ophthalmologist. Next is newborn with difficult labor. Usually newborns with difficult labor, there will be Erb's palsy. But usually they will also give you the description, like how the child looks. So usually there will be a description there, how the child looks. So there will be picture of Erb's palsy. Infant 3 months with left eye deviation. So more than 3 months needs to be referred to ophthalmologist. If less than 3 months, it will be reassurance. Four years, he met an accident and his GCS is 5. Heart rate is 52. RR is 8. So the treatment will be CPR, because any heart rate below 60 is bradycardia, and CPR is considered. So 4 years old, he met an accident, GCS 5, heart rate 52, respiratory rate 8, means maybe he is gasping and his heart rate is below 60. So we will consider CPR in him. Next is child with acute onset diplopia. Suddenly he started seeing 2. When he look at left side and his right eye convert, when he look at left side, his right eye convert and improve the diplopia, which is the affected nerve. So we have to think over this question. This is some tricky question. Let me pause and think. Now, common cause of headache in children. Common cause of headache in children, homocranial headache, increased ICP, tension headache. So if migraine was here, it will be the first choice. If migraine is not there, then tension headache will be the second choice. But I want to check what is holocranial headache. Let me check and come back. Okay, neuroblastoma. Neuroblastoma, poor prognosis is age more than 1 year, and good prognosis is age less than 1 year. We should remember this always. Age more than 1 year is poor, more than or equal to 1 year is poor prognosis in neuroblastoma, and less than 1 year is good prognosis. Next, child with rash all over body, irritability, vomiting, looking ill. So rash, irritable, vomiting, looking ill. What to do along with blood culture, and also if there is option of LP, I will consider LP in this child because there is rash all over body and he is irritable, vomiting, looking ill. So we'll consider LP as well. So it depends upon the options what is given there. Okay, next question. Infant with fever, irritability, rash over the body, bulging fontanelle. So we have so many points here. He is irritable, he has fever, he has rash, and there is bulging fontanelle. Heart rate is 160, RR is 45, and blood pressure. Blood pressure is 60/40. What to do? Again, depends upon is 60/40 low blood pressure in an infant. What is the normal blood pressure in an infant? I think 70. Systolic should be 70. So 60 means low BP here. And there is bulging fontanelle, irritability, rash. So they are considering saline here. Okay, so it depends upon what is the question asked. Maybe if there is LP, we will consider LP in this child as meningitis. Who can tell me? Who can tell me the blood pressure? How do you calculate blood pressure in children? We will end and rejoin again.